Okay. All right. We're getting live on Facebook.
We're getting there.
We're getting there. All right, guys. Hi, everyone. Dr. Chellam and Marina from Holistic and Integrative Center of Novi. And today our topic is polycystic ovarian syndrome. So, Marina, have you heard of PCOS?
I have heard of it.
I know you wrote the copy for it, so you probably
I might
had
have gotten that off of Mayo Clinic. So.
Yeah. Well, that doesn't matter. So here's what. These are for women who have to spend all that money either on razors or getting a wax job or try to get their laser out their hair on their face.
Or the women. So my experience with PCOS, like, I don't think I had any kind of medical knowledge. I remember in high school, my friend had it and just so much pain for her.
Okay, so the menstrual.
Yeah.
Now, PCOS sometimes gets thrown out as a diagnosis without specifically finding out if they have PCOS or they just have a difficult menstrual cycle. Now, the difficult menstrual cycle, I would say, is something that a lot of studies have been done. A lot of it is actually nutritional, but PCOS is also can be nutritional, but we'll get into the nitty-gritty details of that. So hopefully anybody who's joining us, is there anyone who's joined us? Let's see.
We got one person live.
Awesome. The one person, thank you so much for showing up. We really appreciate you. But what we are gonna, hopefully what I want you to see is, can you see my board? And hopefully it's not flipped for you. I think it might be straight, because this is going to be really crucial for today.
All right. Getting a lesson today.
Yeah, today I am going to really teach. It may not be as clear. There's
see a little bit of a glare, yeah. So we got a little bit over a little bit.
I can shut the light off so I don't have to. But anyways, we'll look at it this way. All right.
So for those of you who are listening to the podcast, if you want to see the board and actually get a full experience, you can go on our website at holisticicon.com. And we actually have a bunch of videos there. So there's a video library link and you can click there and the video of this podcast is going to be there.
Absolutely. And it'll take a couple of weeks, but it'll be there. Okay. So let's start with, before you understand when something is wrong, you got to understand when is it right. And I think if you don't know what is right, you're not going to be able to figure out what is wrong, right? You need to know what some people come to us and it's very amazing. They say, I didn't feel like I had a problem till I worked with you and now I see how much I was struggling. Right. Do you remember?
Yeah.
So a lot of times you need to know what normalcy is. So let's go over that. Now in this diagram, I'm not a great artist, but this is what I did. So you have the brain. The brain is always your marker, right? It sees, do you have enough hormones? Do you have enough of the right hormones? If you don't, then it kind of sends out those right hormones or asks the rest of the body, whichever part of the body has to produce the hormones, to produce the hormones. So hypothalamus is the first area that will sense whether you have enough of the hormones. And it produces two specific hormones called, this is only pertaining to the ovaries, that's all we're going to talk about, called LH, luteinizing hormone, and FSH, follicular stimulating hormone. And I'll tell you why this is important.
That's the end of my knowledge, by the way. LH and FSH, that's all I know.
That's good enough. But what you need to understand is LH and FSH comes from the pituitary. So the hypothalamus produces what is called the gonadotropin releasing hormone. Release your gonadotropin. So anything, the gonads would be your reproductive system. It tells you, please release a specific hormone. So the pituitary produces what is called the follicular stimulating hormone. And this thing that looks like a Tesla symbol, I remember when I was driving,
That's what that means.
Yeah.
Tesla's actually very feminist, apparently. By a bunch of ovaries on their cars.
I just hope Elon Musk doesn't come across this video. Because I don't think he's going to like the fact that his symbol actually looks like the uterus with two ovaries. But that's what this is. I love the symbol. So here you can see the two ovaries. Now I've enlarged the egg. And one of the reasons I did this before we got onto the podcast is I didn't want to waste your time drawing it. So let me go into what happens is the menstrual cycle starts on the first day of menstruation for women, right? That's your first day. During the first few days, right up till 10, 11, what happens is your estrogen starts rising. How does the estrogen start rising? Because the follicular stimulating hormone gives a message to the ovaries saying, hey, we need you to produce some eggs. We need some eggs. It's the time for ovulation, right? Getting us ready for reproduction. Now, 10 to 20 eggs actually start maturing altogether. This is where the survival of the fittest really happens. So the FSH gets into the ovaries and makes them produce 10 to 20, and they start maturing at different rates. One particular egg becomes dominant, the rest of them just die out.
Oh, we're so special.
I'm telling you that one special egg will survive. Now, when it matures enough, it releases the egg or the ovum.
Mhm.
Now, if that egg gets fertilized, then whatever is remaining becomes the structure that produces the progesterone. And this is where you will start, it'll either support the embryo and the progesterone and the estrogen, it'll support the embryo, or it just dies out. It becomes what is called the corpus luteum. Corpus means body, luteum. So it gets completely scarred. And that's how people have a lot of different eggs in their ovaries. So when they have that pain, it's multiple eggs are maturing, multiple cysts are there, only one goes out, and some of them just persist and cause a lot of inflammation. And that comes from a hormonal abnormality in the cycle.
Okay.
So let's look at what exactly happens. So the follicle stimulating hormone starts increasing the estrogen. The estrogen gets to a peak. And here's the funny thing about follicle stimulating hormone. It's like that friend of yours that works with you all the way and in the last minute just drops off, right? When it withdraws, the estrogen withdraws.
It leaves you on the stage with your pants off.
Yeah, basically, that's what happens. But what requires the egg to be released is this thing called the luteinizing hormone. There's a sudden surge, the egg gets released, and if that surge is not there, you have what is called an anovulatory cycle. That means you don't produce an egg.
Oh.
This is one of the commonest problems with infertility, which we will be talking about in the next couple of weeks with one of our colleagues. But the luteinizing hormone, that surge is not there. That's a huge disruption.
Mhm.
But today we're going to talk about polycystic ovarian. And then the estrogen begins to fall, but as the estrogen, remember this corpus luteum takes over, it starts producing progesterone. But see, towards the end of the cycle, all of these hormones have gone down. What has to happen here? They all have to be cleared out of the body.
Is this when women are not crazy? Is in those 2 days right there?
Those 2 days, but if they don't clear, then they're going to be crazy. Right? And where does the clearance take place? In our big detox organ, which is the liver.
Yep.
So if the liver is disrupted, then all of this clearance, and you can see why women are crazy. So many hormones go up and down, and one depends on the other. And then eventually, if they don't get cleared because there's something wrong with your liver, then you land up having hormonal dysfunction.
All right. Drinking wine, screwing up our liver,
getting those moody things, and then you start gaining weight in a specific way, or have and I think the bigger challenge is polycystic ovarian. Remember, anything with the syndrome means there are specific criteria, and there are 3 things that have to happen. Number 1 is hair growth. And you have the male pattern hair growth, which means you have a mustache, your beard, the chest hair, hair about the pubic area and the thigh and the arms, even in the back, in very advanced cases, even in the back. The second one is the anovulation. That means the LH surge is not there, the ovaries do not come out. And the third one is insulin resistance. I'm sorry, not even insulin. It's actually an ultrasound picture of the ovaries, and it's described as the pigeon's egg.
Okay. That's where that pigeon egg is from.
Yes. So when they do the ultrasound, they call it. So it has been defined all the way back from the Hippocrates era, saying, hey, these women that look very masculine and cannot have babies, they were called a specific, I can't remember what the name was, but that's how it was. It has been defined for years. Now, this is very important. This is the part that becomes very important. When you have hair growth and you are infertile, you have to be making sure there is no tumor on the ovaries that's producing testosterone that's causing this disruption,
Okay.
number one. And there's no tumor in the adrenals that's causing the disruption. So always make sure that pathology is cleared. If there's no tumor, then you have to look at where is the dysfunction. And this is what we're going to get into. So having said that there are multiple hormones, remember the hypothalamus, the brain gets a signal saying, hey, we don't have enough estrogen or progesterone. It produces a follicular stimulating hormone. Follicular stimulating hormone gets about 10 to 20 eggs, all maturing at the same time. And then the fittest of the egg will be able to mature to, we call it the ripening of the egg, which is kind of like a fruit. I don't know why. And then it pulls out it gives out the egg, and that egg gets into the uterus to get fertilized. If it doesn't get fertilized, then the remaining portion of the egg just dies out. And during this process, you have FSH, you have the LH, you have estrogen on one arm and progesterone on the other arm. It's as simple as that, right? Now, where does all this happen, and how does this happen?
Where were you 3 years ago when I had to study this? I'm trying to figure out what the hell are all these hormones.
Right.
Yes.
So they have, it's almost like an orchestrated band, right? If one of them is out of tune, your system is out of tune.
Yeah.
So you have to see what is it that creates the system to get out of tune. So let's look at where the hormones get formed to begin with. It all starts with cholesterol. This is why you hear most of the times in the functional medical world or in the holistic world, hey, don't bring your cholesterol down. You're not going to be making enough of your hormones. And that is really a false statement. Cholesterol is made in virtually every cell in your body. The cholesterol with the cholesterol lowering medicines, what we are trying to reduce is the one that's produced in the liver, predominantly in the liver. Some people, it goes into their brain, but predominantly in the liver. So the body, even with a very low cholesterol, can make its own cholesterol in its cells and create these hormones. Okay, so having said that, what are the steps that go into the production of these hormones? The main hormones we're going to talk about is testosterone, estrogen, the progesterone, and then we're going to do the dihydrotestosterone also, which is another form of testosterone, but we'll get into how this happens. So cholesterol is formed in your cells. And this is one of the reasons why when you eat a high cholesterol diet, you don't necessarily get a high cholesterol, because we don't absorb the cholesterol into our blood. We only absorb what is called triglycerides, chylomicrons. So cholesterol is made in every cell. Now, the next step is it becomes pregnenolone. Now, pregnenolone is like the parent hormone that can go two different directions. One into the sex hormones and the other into your stress hormones. Two S's, right? So it becomes either a progesterone or DHEA. And now the DHEA becomes this one more step. We'll just call it andro. Andro means anything to do with male. And that becomes testosterone. Testosterone has two ways to go. It becomes a female hormone or it becomes dihydrotestosterone. Now this one requires an enzyme called aromatase.
Ooh, connections.
Right. Yes, aromatase. And this aromatase, you know how to inhibit the aromatase is to eat a raw onion every day. So if you eat a raw onion, you can get a high testosterone level in case you want to increase your testosterone. That's not what we're talking about.
You're also going to lose a lot of friends.
That's true. I mean, but men love it, right? Oh, that's true. With the onions, you mean? Maybe there is a pill on the onions.
Yeah.
So I want to pull up, I want to make sure I give you the definition of ovarian. This is from the National Institute of Child Health and Human Development. It says clinical biochemical signs of hyperandrogenesis. So that is the the testosterone levels are high. No ovulation. That means there's no LH surge. And then addition of the ultrasound criteria of having those multiple follicles So if you have all those three.
So infertility, you do have to have infertility to.
Oh, PCOS is one of the commonest reasons for infertility.
Right.
Yeah.
But that's a requirement to be diagnosed with PCOS or no?
No, PCOS is one of the many
Yeah,
reasons
okay.
for infertility, right?
Mhm.
It's just one of the many reasons. But people get told that they have PCOS if they have just little hair growth, and it could very well be. And here's the part that's very important. It actually is reversible, and we can actually resolve it. It's not, what do people come and say, hey, it runs in my family, my mother had it, my grandmother had it. But obviously, if they were able to get pregnant, it wasn't severe PCOS, something improved their fertility. But yes, a lot of people with PCOS will have infertility issues, but not everybody with infertility will have PCOS.
Right.
Does that make sense?
Yep.
Okay. All right. So one of the things that happens now when you can see this process, like I said, one is progesterone and the DHEA. What happens to the progesterone? It can become cortisol or mineralocorticosteroid, right? And when it goes into here, it becomes testosterone. The testosterone decides which direction it can go.
Mm-hmm.
What they found is, coming back to this ovary, each of this, remember I've written a black circle and a green. The outside is called the thecal cell. The inside is called the granulosa. The granulosa is the one that makes the estrogen.
Mm-hmm.
The outside cell provides the testosterone.
Ooh.
All right. So the testosterone has to get into the granulosa. The aromatase has to convert it to estrogen. Does that make sense?
Mm-hmm.
In a lot of people with PCOS, this theca is so thick. That's where the pigeon's egg comes, and it's producing so much of testosterone, and not enough estrogen is being made in the granulosa.
So you're getting like nodules almost in
You're
your
getting
ovaries.
Thick ovum, thick eggs, pretty much. Now, why does that happen? What they found is we also have on this, just to make it more complex, we also have insulin receptors.
Oh, yeah.
So remember, when you have, I've said this in my hormone seminars, in my thyroid seminars, when you have insulin resistance, you do have menstrual abnormalities very, very early in life. These are the children that would have hypoglycemia, who would have very scant menstruation. And because it's no egg is being released, usually they're painless, almost scant menstrual bleeding, but they start growing hair the minute they attain menarche, which is their very first period. That's very characteristic of polycystic ovarian. But these insulin receptors, what they find is, if insulin cannot work, if there's a resistance to it, this conversion of the testosterone to estrogen also gets inhibited. We still don't know what is the connection, but we find that all of these people with PCOS do have insulin resistance. And if we figure out what is that connection, it'll be so much easier to come up with, I'm sure, a drug, but actually a long-term solution, right?
Yeah.
What they also find is when people lose weight, when the insulin resistance goes off, the ovulation takes place, the whole system begins to work. So we have to somehow address the insulin resistance in a lot of these people. And when people come to our programs, that's one of the things we do, right?
Yep.
We look at the hidradenitis, we look at hair growth, we look at difficulty getting pregnant, all of those things. We put it together, we try to do the testing to determine, hey, are you having too much of your testosterone, not having enough of estrogen? Are you producing proteins that bind to these hormones? These are the things that we delve into and see, what do we need to do as the next steps? Okay, it's not, so you can see here, if somebody is not converting the testosterone to estrogen by giving them estrogen, we're not doing them any favors.
Right.
Because their cycle is completely disrupted. And now that's why a lot of women don't get pregnant unless you look at the whole system and say, how can I remove that insulin resistance? So what puts a woman at risk for polycystic ovarian syndrome? Remember, in functional medicine, our history begins very, very early. We ask, hey, when your mother was pregnant with you, how was her health? That becomes really crucial. Let's say a young woman has a lot of libido issues and she decides she's going to take a DHEA energy and she's going to take some kind of a natural supplement to raise her androgens. and she gets pregnant, that baby is at a high risk. If it's a female child, it's at a high risk for polycystic ovarian. So you don't want the early trimester of the pregnant woman. She should not be exposed to anything that can potentially increase or disrupt her androgens.
Mm-hmm.
So that's one of the common reasons why people have polycystic. Then the other one is, of course, if you have insulin resistance, automatically there seems to be a lot of disruption, and that puts you at a risk too.
Probably if the mom had gestational diabetes, that would put them at increased
absolutely.
risk
In fact, gestational diabetes is one of the risks. So when you really look at it, let me make sure I get everything in for you guys. There is impaired glucose tolerance also, not just gestational diabetes, but if their GTT actually fails, I can see, thank you, Jenny. If the GTT, glucose tolerance test, which we actually do for most pregnant women, especially with the very first trimester, if that they fail, they find this impaired glucose tolerance, then of course they are at a higher risk. If there is a decrease in what is called sex hormone binding globulin. Remember, this is produced in the liver. If there's a problem with the liver, it doesn't produce enough of this hormone. There's an overabundance of a lot of these hormones, and then the brain just shuts down. Mm-hmm. It's exactly like, our cells are just like us. If somebody nags us, we just shut it off, right? And it shuts down if there's too many free hormones floating. And then they also find if you have a lot of inflammation, high sensitive C-reactive protein is high, you're at a higher risk for developing insulin resistance and polycystic ovarian syndrome.
And all of these things are always connected between your liver, insulin resistance, and inflammation. I mean, they all work together.
And I think that's the key thing that we always try to let people know through our educational seminars is don't look at it as something that only, I have polycystic ovarian syndrome. That is not an isolated occurrence. It is a part of your systemic problem. Does that make sense?
Mm-hmm. Yeah.
So when you have a disruption in how many, whether you have a fertility issue or a hair growth issue or high blood sugars or low blood sugars too, get your biochemistry evaluated and see where might be the very first domino that fell. And that's where the history of the mother and pregnancy. So everybody, most of our patients, when they come in their 50s, are like, gotta call my 80-year-old mom and ask her if I don't think she mentioned anything. But that becomes very important because that is where I think we find, if I can address insulin resistance, and I think that's one thing we're very good at, we can resolve a lot of the hormonal issues. Does that make sense?
Yeah, I mean, we're so used to thinking like PCOS, there's something wrong with my ovaries, and it's manifesting in your ovaries, but the issue is way upstream.
And that's where the genetics come. So it runs in families because remember what happens with genetics, your weakest link, whatever is your weakest spot is where you will develop the disease. So if my family has a history of rheumatoid arthritis, when I'm stressed, when my body's broken, I'm going to manifest with rheumatoid arthritis. Right. So whatever is your genetic risk, then if your environment creates this disruption, and this board looks completely disrupted right now, but if it causes this disruption, that's when you land up with a disease. Does that make sense? Yeah. So I'm going to wrap it up with summarizing what happens. The brain gets the information on the levels of the hormones. It produces two specific hormones in women and also in men, luteinizing hormone and follicular stimulating hormone. The follicular stimulating hormone stimulates the follicles, which are the eggs. That's what they're called. Of the 10, 20 eggs, only one will survive. And that one that releases the egg for fertilization, it becomes what is called the corpus luteum that produces the progesterone. But for this release of the egg, you need what is called the luteinizing hormonal surge. If that surge doesn't happen, and it doesn't happen when you have too much of testosterone. And the testosterone is provided by the outer membrane into the inner membrane that produces the estrogen. Testosterone has two ways to go. It becomes estrogen in women. A majority of it becomes estrogen, or DHT, which is another form of testosterone. In people with polycystic ovarian syndrome, this aromatase, for some reason, is not working, and it is connected to insulin resistance.
Mm-hmm.
And so if there's insulin resistance, you tend to accumulate more testosterone and DHT more than you need, and then you start looking like a guy. And you don't make enough estrogen. And if you don't make enough estrogen, then you have a problem. The other problem that can happen is the sex hormone binding globulin may not be enough made in the liver. There's too many of the hormones. The brain just shuts off the cycle. And when that rhythm goes away, you'll end up having infertility issues and polycystic ovarian syndrome. And of course, if you just have glucose intolerance or poor metabolic issues because of insulin resistance, that also leads to polycystic ovarian syndrome.
Mm-hmm. I think the other thing that we didn't quite touch on is it all starts in the brain. And if you're stressed,
I think any disease process begins in the brain, right? And I don't think there's a way anybody can live life unless they are like monks and have learned to detach themselves from the world, because everything really causes stress.
Yeah.
How do you manage stress? And once you learn how to manage stress and your response to stress is different, your hormones actually work in sync. And that's why you'll see it among teenagers. I think having 2 teenage kids, I find that stress plays a huge, humongous role in their health. And they bring on their stress because the world they live in is very, very stressful right now. The competition, the social media, and it's very difficult for them to understand that they can choose their own path. So I think literally what I find when people come, we have to delve into their biochemistry. Why do we do blood tests and saliva tests? So I can connect, we can connect our patients to their problems, and then we can address their stress. That's why we have a life coach, we have a nutrition coach, and then we do the very detailed testing. Because if you don't know all of this and you're just replacing hormones and then getting your hormones checked, or just taking a bunch of supplements, you're never getting to resolve it. There's no difference between supplements, hormones, or medications. Just because one is natural, it doesn't mean it's the right thing. And remember, I think I told you about my recent experience where we had my genetics explained on a podcast. And what happened is I went and bought the supplements to help my estrogen clear out. Remember, this clearing out was not happening because I had a genetic trait where my liver could not convert the estrogen. And I took a little too many supplements and landed up with a headache.
Yeah.
So supplements are not completely benign. You really need to know what you're doing. And if you don't, and if you don't know your body, you might actually be wasting a lot of time and money.
It's true.
Okay. And if there are any questions, I will be happy to answer. I mean, I try to simplify a very complex issue, but that's what I try to do so people understand.
PCOS 101.
Yeah, I know this is like the basic PCOS, just understanding how the hormonal cycle can get disrupted. I don't think we have too many questions.
No.
And half the time we cannot see the questions when we're live, and once we shut off, we see the questions. So
we're not ignoring you. We just don't know how to use technology.
So remember, guys, I will answer the questions if I see them. But again, if you remember, share this video with friends who might be struggling with it and doing the wrong things for themselves by just taking, hormones and supplements. Make sure you like our Facebook page, this Nisha Chellam MD. Make sure you download our videos and please review our podcast. That's the only way we can put out these things. And of course, if you feel like, hey, you know what, this was not good enough information, let us know that too. And I'll try to make it. Marina always tells me, you give way too much information, you're confusing people.
You're confusing me.
I know. That's true. So I'm trying to get it as simple as possible. And hopefully I've made it very simple. Just remember, you don't want to have more testosterone than you need.
Yep.
And for that, your liver, your body, your mind has to be clean. Does that make it? How much more simple can I make it?
Right. Well, so not next week, in 2 weeks, we'll actually be having Dr. John Bartimus on with us.
Yes.
And we'll really delve into the whole fertility and fertility issue. So
Absolutely.
This is like step 1, step 2, and take it a little bit further.
At least you know how the hormones work. So when you watch the infertility podcast, I think it's going to all make sense.
Yeah.
I'm
excited for that one.
Well, thank you so much, guys, for joining us. And we'll talk to you at the next podcast.
All right. Bye-bye.
Bye.